This video is on gonioscopy, and in this video I'm going to read gonioscopy chapter from Arwind's textbook of glaucoma. So this is the part 4 video on gonioscopy. Definition. It's the chapter 13 gonioscopy from Arwind's glaucoma. Definition. Gonioscopy is the biomicroscopic examination of the antechamber angle of the eye. It enables the glaucomas to be classified into two main groups: angle closure glaucoma and open angle glaucoma. Gonioscopy is helpful diagnostically, prognostically, and therapeutically in glaucoma. History of gonioscopy. In 1907, Trentas visualized the angle in an eye with keratoglobus by indenting the limbus. He later coined the term gonioscopy, meaning observation of the angle. Salzman, realizing that the angle was not visible due to total internal reflection, introduced the gonio lens in 1914. Kippe improved it 5 years later by designing a steeper lens and using it in combination with side slit lamp. Otto Bachen established the use of gonioscopy in the management of glaucoma. He used a slit lamp suspended from a ceiling, handheld illuminator, and a Kippe lens to view the angle and classified glaucoma into deep chamber and shallow chamber. He also performed goniotomy using these lenses. Troncoso also contributed to gonioscopy by developing a self-illuminating monocular gonioscope for magnification and illumination of the angle. In 1938, Goldman introduced indirect gonioscopy using the Goldman mirrored contact lens. The Allen lens, which had a totally refractive prism instead of mirror, was developed and later modified into the Allen-Thorpe gonio prism. Gradel and Sugar in 1940 were the first to grade the angle, and she subsequently, in 1957, developed a system of grading based on visible angle structure. The popular Schaffer technique was developed in 1960 and further modified by Speth in 1971. Optical principles. Normally, the angle of the antechamber cannot be viewed during slit lamp examination, as the light rays emanating from the angle strike the cornea at an angle steeper than the critical angle, 46 degree. Critical angle for cornea and air interface is 46 degree, and are refracted back into the eye due to total internal reflection. The solution to this problem is to eliminate the cornea optically. This can be done by using gonioscopy lenses, which are designed to overcome the total internal reflection and exceed the critical angle by altering the cornea-air fluid interface. These include direct gonio lenses. In direct gonioscopy, the anterior curve of the contact lens, gonio lens, is such that the critical angle is not reached, means it is steeper than the antisurface of the cornea, and the light rays are refracted at the contact lens air interface. The Kippe lens is the prototype diagnostic gonio lens and is available in different diameters and radii of posterior curvature. A gonioscope or handheld biomicroscope provides 15 angstrom to 20 angstrom magnification. It may be handheld or suspended from the ceiling with a counterbalance or on an elastic belt. The light source is usually a separate handheld unit, such as the Bachen focal illuminator, although it may be attached to the gonioscope. Direct gonioscopy is performed with the patient in a supine position, preferably on a movable diagnostic table or chair, after applying a topical anesthetic. The gonio lens is positioned on the cornea using a breech or balanced salt solution, a viscous preparation such as methyl cellulose or the patient's own tears. The examiner usually holds the gonioscope in one hand and a light source in the other hand. Occasionally, an assistant may be needed to move the gonio lens to a desired position. Alternatively, a gonioscope with mounted light source may be used, which allows the examiner to control the gonio lens with the other hand. In either case, The examiner scans the antechamber angle by shifting his or her position until all 360 degrees have been studied. Indirect gonio lens. In indirect gonioscopy, the light rays are reflected by a mirror in the gonio lens and leave the lens at nearly at right angle to the contact lens air interface. These are more popular because they can be used to understand examination circumstances with the patient sitting at the slit lamp. They can further be of two types: those whose surface is slightly larger than the cornea and that require a gonioscopic coupling gel, for example Goldman lens, figures 4a and b. Those whose surface is smaller than the cornea and that use the patient's tear film as a coupling agent, for example Zeiss or Sussman 4-mirror lens, figures 4c to e. The Goldman single mirror lens is the prototype. The mirror in this lens has a height of 12 mm and tilt of 62 degrees from the planar front surface. The central well has a diameter of 12 mm and a posterior radius of curvature of 7.38 mm. A Goldman 3-mirror lens has two mirrors for examination of the fundus and one for the anterior chamber angle, which is tilted at 59 degrees. The posterior radius of curvature of both standard Goldman diagnostic gonioprisms is such that a viscous material must use to fill the space between cornea and lens. However, a modified Goldman type lens has been developed with an 8.4 mm radius of curvature, which eliminates the need for a viscous bridge. Goldman type lenses have also modified with anti-reflection coating for use with laser trabeculoplasty. In the Zeiss 4-mirror lens, all 4 mirrors are tilted at 64 degrees for evaluation of the angle, thereby eliminating the need to rotate the lens. We don't need to rotate the lens because the mirrors are tilted 64 degrees, so entire 360 degree view of the antechamber angle is covered at this angle in Zeiss 4-mirror lens. The original 4-mirror lens is mounted on a holding fork holder, while newer models have permanently attaching holding rod Posner lens or are held directly Sussman lens. An adjustable slit lamp mount has also been developed for the Zeiss 4-mirror gonioprism. The posterior curvature of each of these 4-mirror lenses is similar to that of the cornea, which allows the patient's own tears to be used as the fluid bridge. The mirrored arrangement of both these types of lenses causes the observed image of the angle to be reversed but not crossed. In other words, that which is seen in the mirror is 180 degrees away, but its detail is not altered with respect to right and left. Means it is upside down, but the sides are not different. Means superior is seen as inferior, nasal, temporal is seen nasally. Then suppose if we are looking at the superior mirror, okay, then it is the inferior angle that is reflected in the superior mirror. So like that it is. The other important adjustment the novice gonioscopist need master is to apply the absolute minimum amount of pressure of the contact lens on the cornea, especially while maneuvering the slit lamp beam and the lens to maximize visualization. Cleaning of diagnostic contact lenses. Any instrument that contacts the eye creates a potential hazard of transmitting bacterial and viral infection. Human immunodeficiency virus and other infectious agents have been isolated in the epithelium of the eye and in tears. Although transmission of human immunodeficiency virus has not been documented in ophthalmic examinations, it is important to disinfect lenses after each use. The human immunodeficiency virus is sensitive to heat and to a variety of commonly used disinfectants such as alcohol, glutaraldehyde, sodium hypochlorite, household bleach, formalin, and phenol. Unfortunately, many gonioscopic lenses are quite fragile and may be damaged by Some of the recommended techniques for disinfection. In 1988, the American Academy of Ophthalmology, the National Society to Prevent Blindness, and the Contact Lens Association of Ophthalmologists jointly issued guidelines for disinfection. They suggested inverting the contact lens and wiping the surface with an alcohol sponge. For added protection, the lens can be inverted and the concave contact area filled with a solution of 1:10 household bleach, which is laid for 5 minutes and then rinsed off with water. American Academy of Ophthalmology, 1989. Some manufacturers recommend soaking lenses in 2% glutaraldehyde or dilute 1:10 household bleach. Ocular instruments. Value, Washington. I don't know the pronunciation. Value. I don't know. Most lenses can be gas sterilized and some glass lenses can be autoclaved. With all lenses, the manufacturer's instructions for disinfection should be followed to prevent damage to the lens. Technique of gonioscopic examination. Clinical application of gonioscopy. Before I proceed, I would like to cover the charts and figures I'll cover at the end. Techniques of gonioscopic examination. Clinical application of gonioscopy. Gonioscopy is a fundamental clinical test that should be performed on all patients with glaucoma, suspected glaucoma and family history of glaucoma, where some assessment of the width of the angle should be routinely performed on all patients on presentation to any eye care practitioner. Gonioscopy is part of comprehensive eye examination. The examination should specifically aim to identify anatomical characteristics and pathological phenomena that are associated with an increased risk of glaucoma, for example, iridotrabecular contact, angle closure, pigment deposition, pigment dispersion and exfoliation syndromes, trauma, angle closure, uveitis, neovascularization, angle recession, and other pathologies such as iris and ciliary body tumors or foreign bodies. Note, it is important to emphasize the dynamic nature of angle anatomy and particularly that lighting, posture, autonomic function, and systemic medication can all affect angle configuration. Which things? Lighting, pupil size, posture, autonomic function, systemic medication can all affect angle configuration. For accurate assessment of the risk of angle closure, all examinations must be carried out in the dark as even small amounts of extraneous illumination can influence angle width. It is important to remember that an eye's gonioscopic status is not static and determined in perpetuity by a single baseline examination. Long-term dynamic factors such as lens changes, medication effects, aging, and disease processes make periodic gonioscopy an important feature of appropriate glaucoma management. Why gonioscopy? Gonioscopy is an essential component of ocular examination because primary open-angle glaucoma is ultimately a diagnosis of exclusion. One must demonstrate that angle closure is not occurring in order to make the diagnosis. Iridotrabecular contact or sign of previous contact is the defining characteristic of primary angle closure. Similarly, the diagnosis of secondary glaucomas associated with pigment dispersion, pseudoexfoliation, and uveitis can be supported by gonioscopic signs. Gonioscopy is also an important prelude to treatment not only of angle closure with peripheral iridotomy or iridoplasty, but also laser trabeculoplasty for open-angle glaucomas. So gonioscopy, it has got diagnostic value, it has got therapeutic value, and also progression. Examination prior to gonioscopy, central anterior chamber depth examination. Before examining the anterior chamber angle itself, it is useful to consider other aspects of the patient. It helps to know about the age of first reading spectacle use, current refraction, or a history of amblyopia. It is important to assess the antechamber depth and, in particular, to compare the eyes. A shallow central antechamber is associated with angle closure and more pupil block, whereas marked asymmetry can be a sign of posterior segment mechanisms of angle closure. Limbal chamber depth estimation, a modified Van Herrick. The limbal chamber depth (LCD) is assessed at a slit lamp with the illumination column offset from the axis of the microscope by 60 degrees. The brightest, narrowest possible vertical beam of light is directed at the temporal limbus with the beam of light perpendicular to the ocular surface and viewed from the nasal aspect. The beam is positioned at most peripheral point that gives a clear view of both the anterior chamber and peripheral iris and then viewed at maximum magnification. The limbal chamber depth may be graded according to classic grading schemes, for example 1 to 4, table 4, but more recently has been graded as a percentage of the adjacent corneal thickness and recorded as a percent such as 0, 50 or 100%. It gives an idea of the likelihood of angle closure on gonioscopy as well as an impression of the iris profile. Concave iris profiles will be seen to sweep posteriorly in the periphery down to the lens equatorial sulcus before rising anteriorly across the antesurface of the lens and zonules. Conversely, steep iris profiles will in some cases be seen to rise almost in parallel to the corneal endothelium. It is very uncommon to be able to identify a plateau configuration using this technique. The limbal chamber depth is also helpful in identifying cases where gonioscopy artifact has altered the in vivo anatomy of the angle. If limbal chamber assessment identifies peripheral iridocorneal contact but an open angle is seen on gonioscopy, it strongly suggests that gonioscopy is causing artifactual opening of the angle. Means, if we see the limbal chamber assessment, antechamber depth assessment shows peripheral iridocorneal contact, but an open angle is seen on the gonioscopy, means it is an artifactual opening of the angle. Using more categories from 0 to more than 100% has been shown to give better screening performance for angle closure than the traditional Van Herrick method in high-risk population. In high-risk population, percentage method is better for screening purpose than Van Herrick method. Standard photos are available in the report on this technique have been published. Now, which lens to use and the procedure of gonioscopy I'll cover tomorrow. Now I'll see the charts and figures. Figure 1. Light coming from the angle of antechamber undergoes total internal reflection at the tear-air interface. Thus, the angle cannot be visualized directly. So in figure 1, they are explaining why we cannot see the anterior chamber angle normally because of the phenomenon that is called as total internal reflection. Means when the light rays passing from the denser medium to the rarer medium. Denser medium here is cornea and the aqueous humor, anterior chamber, okay? And the rarer medium is air. So when the light tries to pass from the denser medium to the rarer medium, and if the angle of incidence exceeds the critical angle for that pair of denser and rarer medium, if it exceeds that, then the light rays, instead of going or getting refracted into the rarer medium, that is air here, it gets reflected back into the denser medium, and here it is cornea and aqueous humor, anterior chamber itself. So figure 1 is showing why we cannot see the anterior chamber angle normally. It is because of the total internal reflection. And what is critical angle? It is the angle of incidence for which the angle of refraction is 90 degree. When the light is passing from the denser medium to the rarer medium. And for cornea air interface or cornea tear film and air interface, it is 46 degree. So angle of incidence should not be more than 46 degrees, which normally is, to visualize the antechamber angle. Figure 2, direct gonioscopy performed with a step concave lens which permits light from the angle to exit the eye closer to the perpendicular at lens air interface. So in figure 2 they are explaining the principle of direct gonioscopy. So we have to, now here the angle, critical angle is not altered. The refractive index of the contact lens and the cornea is same. And that's why at the cornea and the lens interface, the light rays are not refracted. Okay, the refraction or reflection is not occurring at the cornea and lens interface. And even the bridging substance that is required, be it Bennett's salt solution or be it viscoelastic substance, they have the similar refractive index, and that's why there is minimal or no refraction occurring at the cornea and the lens interface in both direct and indirect gonioscopy. But in direct gonioscopy, what happens? There is no mirror, and the anterior curvature to decrease the angle of incidence, at the air and the contact lens interface, the anterior curvature of the direct contact lens, direct gonioscopy lens, the anterior curvature is steeper than the cornea, means it is more convex. More convex, so that the angle of incidence is reduced than the critical angle. So the light rays are refracted into the rarer medium. Here it is air. So we can see the angle. It can reach the examiner's eye. So direct gonioscopy principle is that it reduces the angle of incidence than the critical angle. Here the critical angle is same, 46 degree. Everywhere in direct and indirect gonioscopy, there is no alteration in the critical angle. There is alteration in the angle of incidence here by using more curved anterior curvature of the contact lens. It is steeper, means more convex. Indirect gonioscopy. Now in figure 3, they have explained the principle of indirect gonioscopy. Uses mirrors or prisms to overcome the problem of total internal reflection. Now, indirect gonio lens, it has got the prism, or we can see the mirror. So when the light rays passing from the angle, they are not reflected at the cornea and the lens interface, and they are incident on the mirror and are reflected perpendicular to the contact lens and the air interface, and can reach the examiner's eye to see the antechamber angle. So that was all about the principle of gonioscopy, direct and indirect gonioscopy, and the reason why we cannot see the antechamber angle normally. Now table 1, indirect gonioscopic lenses, Goldman single mirror, mirror inclined at 62 degree, Goldman 3 mirror, mirror for gonioscopy is at 59 degree, size 4 mirror, mirrors inclined at 64 degree, requires a holder, unja. Posner 4 mirror, modified size with attached handle, Sussman 4 mirror, finger handheld size type, Thorpe 4 mirror, 4 mirrors inclined at 62 degrees, requires fluid bridge, reach tuberculoplasty lens, 2 mirrors at 59 degree and 2 at 62 degree with convex lens over 2. So 4 mirrors, they give entire 360 degree view of the angle. The mirrors are angled in such a way that they give the entire 360 degree view of antechamber angle, so we don't need to rotate, and also their posterior curvature is similar to that of the anterior curvature of the cornea, so there is no gap between the posterior curvature and the anterior curvature of the cornea. We don't need the bridging substance there. So viscoelastic substance, that uncomfortable sticky sensation and blurring of the vision after the procedure. Also while rotating, it causes discomfort to the patient when we rotate the lens. So these three things are eliminated when we use the 4 mirror lenses. And also we can do the intentional gonioscopy, that is pressing, because they have the smaller contact of area between the cornea and the lens relatively as compared to the direct, because if it is larger as like seen in the direct gonioscopy or with single mirror lenses, the contact area between the cornea and the contact lens is more, so the pressure on the cornea with the contact lens, be it direct or be it indirect with single mirror Goldman lenses, what happens, they have the large surface area of the contact, so on placing the cornea they cause distortion of the anterior chamber angle structures. Okay, they cause the distortion of the angle structure, so distortion of the view of the angle. But as the four mirror lenses, modern four mirror lenses, their surface area, the contact surface area is smaller, so on indentation it pushes the indentation, it pushes the aqueous humor to the antechamber angle, and when it is a positional closure, antechamber angle opens, and when it is a synachial closure, it doesn't open. So to differentiate between synachial, if there is iridotrabecular contact, whether it's synachial or whether it is oppositional, we can differentiate it using the indentational gonioscopy while doing indirect gonioscopy with four mirrors. Now figure 4A to E. A Goldman 2-mirror lens for indirect gonioscopy. B Goldman 3-mirror lens. 3-mirror 2 for fundus and 1 for angle. Sussman 4-mirror lens. D Posner lens and Zeiss lens. Sussman is sessile, means it doesn't have a handle. Posner is size only, but it has permanently attached handle. It is attached to the handle permanently. And Zeiss is Posner only, but it has, means it can be used without the handle, or it can be mounted on an unja holder, that is the handle. Table 2, guidelines by American Academy of Ophthalmology to disinfect the lenses, gonioscopic lenses. Invert the contact lens. Wipe the lens with alcohol sponge. Fill concave area with 1:10 solution of household bleach. Leave for 5 minutes. Rinse with water. Some manufacturers also recommend 2% glutaraldehyde. Most lenses can be gas sterilized, and some glass lenses can be autoclaved. Usually when the lens it comes with that manual, with that paper manual, and on that the sterilization procedure for each kind of lenses it is given there, so we have to follow that. So guidelines by American Academy of Ophthalmology, we can use the alcohol sponge, alcohol, household bleach diluted 1:10, and 2% glutaraldehyde can be used. And most lenses can be gas sterilized, and glass lenses can be autoclaved. Gas sterilization, autoclaving, alcohol, glutaraldehyde, and household bleach diluted 1:10. Leave for 5 minutes for alcohol and household bleach, and rinse with water, because alcohol and these chemicals can cause abrasions on the corneal epithelium. They can damage the corneal epithelium. Uses of gonioscopy: diagnostic and therapeutic. Diagnostic: visualization of anterior chamber angle in eyes with narrow peripheral anterior chamber depth, in eyes with clinical or historical evidence of angle closure, for classification of the glaucoma, family history of the glaucoma. Diagnosis of the glaucoma and classification of the glaucoma. Glaucoma suspects: to note the presence and extent of neovascularization, to assess angle recession, evidence of inflammation, extent of tumors, degenerative or developmental anomaly, planning management. Gonioscopy is a part of comprehensive eye examination. Now, therapeutic uses of gonioscopy: argon laser trabeculoplasty, laser goniopuncture after NPGS, reopening of trabecular ostium, laser trabeculoplasty, laser goniotomy, and cyclophotoablation. These topics I'll cover after gonioscopy. Table 4, Van Herk estimate of angle width from anterior chamber depth at the periphery, grade 4, 3, 2, 1. Slit angle and closed angle. Grade 4 is open. Now the depth is Now, how the depth is assessed? Anterior chamber depth is compared with the corneal thickness, and it is similar in grade 4. Grade 3 is anterior chamber depth is anterior chamber depth equals to 1/4 to half of corneal thickness. Grade 2, anterior chamber depth equals to 1/4 of the corneal thickness. Grade 1 is anterior chamber depth equals to less than 1/4 of the corneal thickness. Slit angle means anterior chamber depth is slit-like. Closed angle, absent peripheral anterior chamber. Table 5, SEAGIG, Southeast Asia Glaucoma Interest Group. Guidelines for gonioscopy. Use a magnification of 20 to 25x, 10 to 25 times. Use a fairly short and narrow beam, 2 to 3 mm. Use a dark room. Pupillary constriction makes a narrow angle appear more open. The slit beam should not cross the pupillary margin. Now, anterior chamber depth, they have explained the grading of anterior chamber depth and the procedure also. I would like to add a very nice video at the end of this video about anterior chamber depth examination. Literally, certain things I myself didn't perform, or I have not seen anyone performing this kind of technique in my during my post graduation. I have not seen how to assess the anterior chamber depth by the other technique that she has mentioned in this video that I'm going to add at the end of this video. You should see that thing, and I really liked the way she's explaining the procedure of anterior chamber depth in a very soft and calm language, composed language, and she has explained it very nicely. I came to know another method to assess the anterior chamber depth at the slit lamp, and that is Smith's technique. I have never seen that technique. I have never seen anyone in my post-graduation or even during my FICO training, anyone using that technique to assess the anterior chamber depth. It's a Smith's technique. And I don't even know if our slit lamp in my post-graduation college or when I was taking the FICO, where I had my FICO training, I have never seen anyone doing that technique. So I don't even know such kind of calibration is present on the slit lamp. So when I join, I would like to see if such kind of calibration is present where I'm gonna work. I don't know where I'm gonna work, but I'm on the long-term video retina surgery fellowship. So during that time, I think like a very decent and good institute where all the instruments are working nicely and properly, because at government, like the instruments, they don't work properly and there's a lot of politics also. So let it be. But I would like to perform this Smith's technique. I hope the consultants over there know because I have never heard any consultant asking me about or telling me about this technique. I myself, I even in other books, I didn't even come across with this technique in other books. I didn't read the entire standard books during my post-graduation. I just wanted to pass with average marks and just wanted to be back to something. So for sure you watch this video. I have really liked this video because I never knew that Smith's technique existed. So thank you so much for listening to me patiently. Good night, take care, and do watch this video on the technique of peripheral anterior chamber depth evaluation. Thank you so much. Good night.
So one method that allows you to check the depth of the anterior chamber is Van Herrick's technique. In order to perform Van Herrick's, the observation and illumination systems have to be separated by exactly 60 degrees and locked into place. Use a narrow beam placed exactly at the limbus, and essentially you are comparing the thickness of the section of the cornea with the dark band of anterior chamber exactly adjacent to it. You ignore the iris band and you are comparing the thickness of the cornea to the thickness of the anterior chamber. For a grade 4 or a wide open angle, you expect the ratio to be 1:1. It is easier to measure the anterior chamber angle depth using Van Herrick's temporally, but some argue it's very important to also measure it nasally, as it tends to be slightly narrower nasally. The narrower the chamber is, the less likely you are to dilate the pupil, so it's important if someone's anterior chamber angle is narrow that you check it both temporally and nasally. You have to be careful of the nose when you're measuring nasally, so just always check before you swing the illumination system round that you're not going to hit the patient's nose. And again, you're locking it at 60 degrees and you're placing the beam at the limbus. If you are aware that your patient's nose is obstructing the illumination system, you are able to ask your patient to rotate the head round while still looking straight ahead, like so. And again, placing the beam at the limbus. So in order to perform Smith's technique, the observation and illumination systems must also be separated by 60 degrees, and the beam must be rotated so it is horizontal. Then what you will do is place the beam horizontally across the cornea. You start with a short beam and you will see a brighter beam which is placed on the anterior cornea, the epithelial surface, and then a duller image which is placed on the surface of the anterior crystalline lens. What you're doing is using the slit height, so you're gradually increasing the slit height until the two beams just appear to touch. At that point, you then take a reading from the graticule and you multiply the reading from the graticule by a constant correction factor of 1.4. And that will give you a quantitative measure of the anterior chamber depth.